The drug that we're talking about is an antibody-drug conjugate. The target is TROP2. TROP2 is an antigen, a cell surface antigen, that's expressed in a wide variety of epithelial cancers. So the initial phase 1 portion was done in refractory solid tumors, essentially. And the company, the sponsor, who we had discussions with at the very beginning in designing some different studies, based on a combination of level of expression preclinically and in some clinical samples before the study started, and those tumor types that had an unmet clinical need, there was an idea of expanding in certain tumor types. Specifically to urothelial cancer, our center, we enrolled 4 patients in the phase 1 part, and it was interesting. These were very refractory patients that had been through a number of different lines of therapy, and all of their tumors shrank. Some were true partial responses by RECIST, some shrank by 20 to 25% and then stayed. And that was in combination with fairly good tolerance, not a high side effect profile. So we had discussions with the company, and we decided to do a phase 2 expansion in platinum-resistant urothelial carcinoma. Overall, urothelial carcinoma is reasonably common if you take all grades and stages, more than 60, 65,000. Just really in the bladder per year, and there's also an incidence in the upper tract, which is the ureter and the renal pelvis. Most of them are localized disease that are treated with surgery and or intravesical therapy, but somewhere between a quarter and a third will often go on to progress and develop metastatic disease or advanced disease. Some will present like that at presentation. What we've developed over decades is really a drug with other drugs around it, cisplatin. So we have cisplatin combinations. The most common cisplatin combination is a doublet with gemcitabine. We also have the kind of old standard MVAC. But we haven't really, even though we've done a number of different clinical trials, we haven't really done much beyond that. For those patients that have metastatic urothelial cancer beyond platinum, there's nothing. So in Europe, worldwide, there was a phase 2 trial that led to the approval of a drug that's called vinfluning in Europe. It did not have a survival benefit in intent to treat analysis, so was never brought before the FDA for approval, but did get approved in Europe. But still, we're talking about a less than 10% response rate and a relatively short overall progression-free and overall survival. There are some other drugs that we can use off-label, taxanes, pemetrexed, but again, what we're talking about is a pretty small overall response rate, less than 10%, with progression-free survival that's measured in 2 to 3 months, typically, with overall survival that's less than a year, typically between 4 to 9 months in clinical trials. We are quite hopeful in urothelial carcinoma, as well as in a lot of other cancers with immunotherapy. And in particular, the PD-1 and PD-L1 checkpoint inhibitors look exciting. And like in other cancers, those patients that respond can have a durable response with generally overall good toxicity profile, but it's a limited patient population. When we take all comers, it's generally a third or less that will have a response. And then when you restrict the patient populations to those with PD-L1 expression, whether we're talking about on the tumor or in the stroma, it's still a limited patient population with a limited response rate that still generally does not go above about a third of patients. So another way of saying it is there's these patients that are out there that we can enroll in clinical trials. Luckily, we have something like this, but it's a very limited portion of the overall patients that have access to clinical trials. So the antibody is a humanized antibody against TROP2, as I mentioned, which is on the cell surface. TROP2 is on the cell surface of a number of different tumor types, is overexpressed in urothelial carcinoma, both cell lines as well as in human patient samples. It's conjugated with SN38, which is essentially the most potent metabolite of the drug irinotecan. That drug alone is really too toxic to be delivered in a free form. So hence we have the antibody-drug conjugates. There's a number of them out there. This particular one, it's interesting because we know that one of the dose-limiting toxicities of irinotecan is diarrhea. And interestingly, this particular antibody-drug conjugate, the formulation, and likely because of where it's being delivered in the body, there's not a lot of diarrhea. In this particular phase 1/2 study in urothelial carcinoma, we were at 8% grade 3 diarrhea. There is myelosuppression, so that's the dose-limiting toxicity with predominantly neutropenia, but majority don't have febrile neutropenia. There was a phase 1 dose escalation study that included urothelial as well as a number of other different tumor types. Was up to 18 per kilo, where there was some toxicity. And essentially, how we arrived at what we're looking at is 8 to 10, generally 10 per kilo for urothelial carcinoma, is basically looking at the overall patient population, and was kind of a little bit between where we saw the responses and where we saw the toxicity. So we're not treating at the true MTD. It's a little bit lower than MTD, but that's looks like to be a nice combination of an effective dose without a lot of toxicity, again, predominantly myelosuppression. So the study's still ongoing, but what was interesting in the very initial part with the phase 1 as well as with the expansion into phase 2 is that we are seeing objective RECIST responses. As of right now, the preliminary data that's being presented is a 50% response rate by RECIST criteria, and these are in patients that have refractory disease, that have had a number of lines of prior therapy. And in this group, 80% actually had visceral metastasis, which was a poor prognostic factor for urothelial carcinoma. So at an early time point, that looks very interesting. Even more preliminary is the progression-free and overall survival, but again, compared to historical controls, whether we're talking about phase 3s or phase 2 studies, it also looks favorable. Based on the available results, I think this looks quite promising to have a 50% response rate in a refractory patient population. We know that there's some good drugs that are emerging in terms of checkpoint inhibitors, but the majority of patients don't respond to those. And this is yet another drug that I think will give us hope, give us as well as patients hope.